also any person that's on the call today, to email me, text me, whatever, let me know that you're on the call so that I can put your name on the roster for the attendance list. So make sure you email me, text me, something like that to let me know what's going on. I see 15 participants, but I know there's others on there also. So just let me know. All right, guys, good morning. In the interest of time, I've got about 9:01. We're going to get started. Welcome to EMS Audit Review for April 2022. A couple things I want to discuss. I will discuss afterwards. I have several things I want to tell you guys that you need to know, but we're going to get right into it. Our first report is going to be a STEM report by Brenda Williams. Brenda, thank you very much.
Thank you. Good morning. Again, I'm Brenda Williams. I'm the manager of the inpatient telemetry unit to stay here at Union Hospital, and I'm also the chest pain coordinator. Go right to the STEMI report. So for this EMS run, it started at 9:47. They were dispatched to Jackson Towers for a patient with chest pain. By 9:52, they arrived to find a 56-year-old female sitting in a chair in the mailroom of the facility. Patient speak warm and dry, reports that she has bilateral pain in her jaw just below her ear, a burning in her throat, and chest pressure. Reports taking 2 nitro with relief before they got there. Patient stood and pivoted to cot with no difficulty. By 9:55, they'd received her or got her vital signs. Her blood pressure was 160/100, heart rate of 110, respirations 18. She was 100% under MER. She took a blood sugar, its glucose of 171. She wasn't complaining of any pain. At 9:56, they got an 18-gauge IV lock established in her right AC. By 10:01, they got the 12-lead EKG. It showed elevation in V1 and ABL with depression noted in multiple leads. Patient reports that she has a thoracic, aortic, and abdominal aneurysms. That she's had 9 cardiac stents in the past. She denied any abdominal or back pain. She denied any nausea or vomiting. She had no known drug allergies. Between 10:04, at 10:04, they gave her 324 milligrams of aspirin. They got her transported to a hospital with no further complaints or pain or discomfort. She got to Union Hospital by 10:33. By 10:40, that she was assessed by the ER physician. Reports that she stopped her Plavix weeks or maybe even months ago due to recent dental surgeries. She was now having some mild shortness of breath and was complaining of increased heaviness sensation to her chest. By 10:43, an EKG was obtained showing inferolateral ST elevation, MI. By 10:51, the cardiologist was consulted and recommended calling in the cath lab. A nitro drip at 10 mics per minute started for chest discomfort, jaw pain, and hypertension. Ativan was administered for anxiety and hyperventilation syndrome. By 11:25, she arrived to the cath lab procedure room. Between 11:30 and 11:46, a sheath was inserted in the left femoral artery and left coronary artery. Angiography performed in multiple views. They had a lot of problems getting through on this one. They're trying to get through stents that were occluded. 11:48, a balloon catheter across the target lesion after several attempts to cross the total occlusion. By 12:09, the stent was across the target lesion. By 12:12, second stent across target lesion in an overlapping fashion. It was interesting to even read about this, the way they were able to go in there and get that. I kind of wish I could get video footage of some of these.
Maybe neat, we can put it up there.
Yeah, and I'll ask one of the cardiologists if I could get something like
I
that. It would
think
be
the game
interesting.
side, they've done it before. So
Okay, well, and I can maybe see if I could get something
that'd
like
be
that.
cool.
Successful reduction of 100% occluded lesion of the proximal right coronary artery to 0% with angioplasty and adjunctive stenting. Her balloon to door time is still 75 minutes. For all the problems they ran into, they still got it in 75 minutes. So I thought that was awesome. Just shows everything you guys do to get them here to us on time makes a big difference. So great job. Summary of door to balloon times, we only have through February right now, the March numbers. We're always at least a month or two behind, just the way our information gets uploaded. But for January and February, we're 100%. And I thank you for all your hard work. Thanks.
Thank you, Brenda. Appreciate that very much. Short and sweet, we like that. Appreciate it. I know you got stuff to do. I had to figure it out. So, hey, the next we're gonna jump trauma up ahead, because Beth's got a stroke presentation, but then Dr. Fishwell is gonna speak about stroke. So Trent Herring is gonna do our trauma report from this time.
Morning, everyone. My name is Trent Herring. I am the trauma coordinator. I work with Jackie, who normally does this, but she had previous obligations, so I'm stepping in. Bear with me. This is my first time doing something like this. Okay, case that I picked out for this was a kind of a selfish reason. I picked it out because it was interesting to me and I hadn't seen it before. So unfortunately, this was a 14-year-old male, and the EMS was dispatched initially for a mental emotional juvenile, and then was quickly upgraded by police department to a gunshot wound, unfortunately to his head. The fire department on scene stated the patient needed to be tubed due to shooting himself in the head, and the patient was found lying in bed with agonal respirations, and his face was very, very swollen. Initial assessment from the EMS, his left eye was swollen. He hematoma formed around his left eye. Blood was coming from his mouth and nose. Interest was located underneath his chin and was out the top of his head. They placed a cardiac monitor, and he still did have a rhythm. It was the sinus tachycardia. Have a pulse at that time. And immediately almost tried to intubate him, but they inspected his mouth and they couldn't find no clear visualization of the vocal cords due to all the damage was within his mouth. That unfortunately, the bullet had went through his palate, through his tongue, and out bottom to top. They suctioned and tried to manually ventilate him, and the decision was made pretty quickly to do a cricothyrotomy, which is this is the part that I had never seen, so it interested me. So they did that fairly quickly. They did the size 6 ET was used and confirmed condensation in the tube and lung sounds and through the ETCO2 monitor. They secured the tube before forgot tape in the tube holder. Patient was taken off the monitor and carried out. He was in the basement of a house and had to zigzag him up and out of the house, so they got him out as quickly as they could and got him up to the ambulance. They put him back on the vitals, and they attempted vitals, and they couldn't get a blood pressure initially. They still had a heart rhythm or pulse at that point. They did an IO. It was the quickest thing to do, and got a bleeder saline started on a pressure bag. The initial vitals, like I said, initially they were unable to obtain blood pressure. His heart rate was tachycardic, and he was getting mechanically assisted respirations at that point. His GCS was 3. They did finally get a pressure. It's 70/43. His heart rates remained tachy. He became tachypneic along with mechanically assisted ventilations until they got to the ED. Of course, this was an obvious level 1 trauma alert. That's not why I didn't get the presentation. It was mainly because when we got to the ER, I don't know that he would have made it that far if they hadn't done the cric.
Absolutely.
That's the point of me doing this. I said if there was going to be a good outcome, that was the only way it was going to happen. That happened. So here's the part that I want to get to. So he obviously arrives at the gunshot wound, the entrance is under the chin, out the top of the head. He was level 1 trauma, and trauma surgery was in ED when they arrived. Actually, I had 2 trauma surgeons, Mark and Dr. Rees were there when the patient got there. They stabilized, got 2 more peripheral IVs, and Dr. Lynch ended up starting the femoral trauma line. The O2 saturation was a little low, and all they had to do was just minimally adjust the carotid tube and secure it. I mean, and all 3, the ED doc, the Dr. Lynch and Dr. Rees all commented on how good of a job that the carotid was performed doing it. So they wanted to give kudos to the EMS for that. So that was kind of my whole point of doing it for you guys, because this was something I'd never seen, and I know you guys like hearing when you do a good job.
Absolutely.
So after they reached this secure thing, the patient ended up getting 2 units of blood and normalizing his blood pressure as best we could. And obviously the patient was shipped out, but we got, we didn't take him to CT or anything, and very obvious what his injury was. They did a fast, but it was negative, but they ended up transferring as quickly as they could to.
They fly him,
They did not fly him.
ground transport?
They had to do ground transport because it was weather at the point that morning. There was storms around.
Okay.
Here it wasn't raining, there was storms around
I see,
Indy, so
yeah.
they ended up having to ground him. So you do. So this is why I did it. So how do you guys, how quickly do you recognize that you're going to have to do something like this? Because to me, I'm not familiar with EMS protocols and how you guys decide. I mean, it's obviously if you can't find the airway,
Yeah.
but how often does this happen?
It's rare.
That's why I said I want to get feedback from the EMS guys out there, because I didn't know. I mean, I just haven't done something. I haven't seen it. So
It's the only one recently that I've seen. It's the only one since we started the trauma program 6.5 years ago.
You agree with that?
so how is this competency done? Is it just taught in school and then you're just expected to know how to do it?
Yeah, a lot of patients, if they'll go to conferences and stuff, sometimes they have cadaver labs, and sometimes that is CRIC is a skill that's done through ITLS and PHTLS also.
Okay, see, that's why I didn't know if it was
Yep,
something
sure.
that you're like.
And the advanced level is it's a skill that is practiced in that type of setting.
Yeah, again, like I said, you guys said Mark's on the line, and I know that he and Dr. Reese both said that they did a good job, so.
Good.
Okay.
Yeah,
so-
I was quite impressed, and it's a real fine border between being a cowboy out in the field and doing something you should be doing. It was totally appropriate and it was done well. So I mean, that's they deserve a lot of credit for that. But I've seen people that have always wanted to do one and have always been anxious to do one, and they've never gotten to do one. But about the time you quit looking for one of these and you don't think it's ever going to happen, it's going to show up.
Yeah.
So everybody needs to know how to do one, and everybody needs to be able to make that decision to hey, it's not working otherwise, and he's going to die otherwise. We can't do any worse than that,
True.
So,
and I ended up doing a little bit of research just because out of my curiosity. This is obviously you go through the procedure in placing a tube through the incision, brachithyroid membrane, establish an airway. It's a last resort for the only thing you got left.
Yep.
What I understand.
you can use any type of tube. I think the 6 tube is excellent. A 4 tube is okay. You can use a thick pin if you have to, although it's not got a big enough hole on the end of it hardly. But you can actually get oxygen in through it anyway. But yeah, you can use what you got there. I mean, that's what you got to use.
Yeah.
So interesting, good case. It's a shame they didn't have more to work with.
Yeah, right. That's what I
Did
said.
they get organ transplants or anything out of this guy?
They did not, unfortunately. The family did not
Okay.
agree to it.
No.
It was very.
Okay, because it's interesting how we kind of think all has failed, but then sometimes these things get harvested for 5 or 6
Well,
years.
and that's what I was kind of disheartened when I heard that they did not. I mean, that was unfortunate.
Would have been good. So
Nothing else.
okay.
So anyway, the emergency medical service-based studies report that 0.5% of patients requiring advanced airway management underwent this procedure. So that's how rare it is. Obviously, the recognition need, assessment and action, quick recognition, inability to intubate them orally. All this is, and then again, I've already went through this, how many of you actually performed this, and we
Yeah.
pretty much figured out it's rare.
Very rare.
So,
Yeah, very rare.
all right, so I don't even know if I need to go through all this. I went through all this already once. Why is it going back?
You're right.
Okay, so yeah, I went through all this stuff already, confirmation to consternation, all the stuff that happened. So obviously this, again, this wasn't a question of whether this was a trauma. Obviously it was a trauma, so this is our inclusion information for the trauma, penetrating traumatic injury of the head, neck, torso, and groin, GCS less than equal to 8. Intubated or assisted ventilation, systolic blood pressure less than 90, heart rate greater than 120. So our process is, obviously, when they get to the hospital, trauma team is activated, our assessment are within 15 minutes. Obviously, in a case like this, normally level 1, there's 3 nurses and the doctor standing there waiting to roll in. And we met all these during this process, and he was transferred to Riley Children's Hospital. He was unfortunately expired after being taken off life support measures at Riley, and I think it was within 48 hours. That's there again.
Yeah, actually, the outcome probably changes to where they don't even get to
Right,
change.
doesn't even make it to the
Yeah.
hospital, but it doesn't get done. Okay.
I really do wish that had been a harvest if it had been
Yeah,
possible.
I do too, Kurt, I do too. Thank you.
Thank you, Trent, you did a great job. I know it's your first time that you've done it, and I appreciate that very much. Next up is gonna be Beth Harrison. Beth is going to do her stroke case study, and then after that, Dr. Fishwell is gonna talk about some stroke for our educational presentations. Thanks, Beth, appreciate it.
No problem. Good morning, everyone. I am Beth Harrison. I am a stroke coordinator. I was very sick here at the hospital. And I want to tell you, every month I have my data abstractor send me all the EMS cases. And I really went through them. I was trying to find a bad one. And you know what? I couldn't find a bad one. I want to say that EMS does an excellent job with stroke in this community. And I really do want to thank you for that. You know, just calling that, identifying that stroke, that large vessel occlusion, let us know that that's a possibility so we can get them on that CT scanner. You know, we're saving so much time, and I really do appreciate all your hard work on that. You know, our biggest issue that we're having is our patients are not calling EMS for a stroke. They're staying at home waiting, you know, taking a nap, hoping that stroke will go away, and it's not. So, you know, I have really been doing a lot of patient education with that, so trying to make you guys a little bit busier. In this case, I get the wrong one. I think I got the wrong button. There we go.
There you go, there you go.
I am not tech, so please forgive me. This patient was a 69-year-old female, and she was found on the floor by her family at 6 a.m. Her last known well was 10 p.m. the prior evening before going to bed, and she told her family that she had slid off the sofa. The interesting one, they found her on the floor at 6 a.m. They did not call EMS till 9:36 the next morning. So EMS, they arrived on scene at 09:47, departed from there at 10:22, and arrived at Union at 10:32. EMS stroke alert was called to the ED via eBridge, and they did report a positive VAN score. The funny thing is, this patient was alert and oriented. She did have left hemming neglect. Her left upper extremity was flaccid. And I'm sorry, that should say, and her left lower extremity did show a little bit of effort against gravity. So if you think about it, the upper was flaccid and the leg had a little bit of movement. So we're talking an interior circulation stroke. You know, we're talking the front of the brain. She did have a left facial droop, and she had left gaze deviation. She did have a history of hypertension, and her initial blood pressure on admit to the hospital was 190/112. She went directly from cart to CT scanner. And the NIH on arrival to the Union ER was 14, and that is very high. You know, even anything over 6, we're thinking possibly large vessel occlusion, and she was at 14. They went ahead and did a CTA and a CTP, which shows us if she has a clot in that artery, and the CTP shows us how much salvageable brain we have. We look at what's called for the penumbra, and that is the brain that could be salvaged if we can restore circulation to it. This showed a large thrombus present in the M2 branch of her right MCA. If you think about your MCA territory, about this much of your brain right here, large part of your brain when you have your MCA infarcted. The patient was not a candidate. It was a wake-up stroke, and we had no definitive last known well. She had a large ischemic infarction in the right MCA territory. And when they did the CTP, there was considerable reversible component of 50% of the right RCA territory. So a mechanical thrombectomy was recommended, and this patient was transferred to IU Methodist via flight. The patient did receive the thrombectomy at IU, but I don't have any information on the procedure because we can't see their EMRs anymore. Unfortunately, she did not have significant improvement post-procedure, even though she had a penumbra of 50%. But I couldn't see how well they were able to restore circulation. We look at that with what we call a TICI score, and I did not have that available. So I'm saying they probably could not get that lesion open. She spent quite a bit of time, ended up with a PEG tube, feeding tube at IU. They eventually transferred her back to a local SNF. And she was just here in the hospital with a significant seizure disorder. She is not doing well, unfortunately. But the highlights of this opportunity was that stroke alert was called, the VAN score was completed, and this case had very good documentation by the EMS. So I really do appreciate that. And this is just one of those cases where we did everything right, but unfortunately didn't have a great outcome.
The outcome was going to be changed.
Right.
Okay.
So thank you guys for all you did.
Thank you.
Thank you.
Thanks, Beth, appreciate it. All right, guys, Beth, thank you again for that. The next thing's gonna be, Dr. Vishwa, you're on. You're going to be up next. I will be glad to advance your slides for you. I can try to let you screen share, but I think it'd be easier if I just did it for you, okay?
And that's fine, Barry. Thank you very much for the opportunity. And Beth, thanks for the presentation. It was great. I just want to thank all the EMS people, what a phenomenal job you guys do, and then help our stroke patients get the treatment what they need to be. So I'm just going to briefly talk about how important it is to timely treat the strokes and what we exactly do in the hospital and before arrival to the hospital. Next slide, please. So we're going to talk about what exactly briefly about the stroke is, what are the recommendations, and what stroke protocols that we do outside the hospital, and in the hospital, what's the stroke hospital care is. And I know that you guys do a great job with the VAN scoring. I'll just briefly talk about what exactly those scores mean and how it helps us in deciding the treatment and pre-notification and stroke treatment. Next slide, please. As you all know, it is a medical emergency, and the stroke occurs when the blood flow is cut off, either reduced or depriving the brain of the blood and the oxygen. It is the 5th leading cause of death, and on average, every 40 seconds, one has a stroke in US. So this is growing as the vascular risk factors are increasing amongst the population. Next slide. There are different types of strokes. The one commonly we see is the ischemic stroke. And this is caused by blockage in the artery, which stops the blood flow and also oxygen to the brain. 87% of the strokes are ischemic. And these can happen due to embolism, meaning a patient may have a clot either in the heart or in the blood vessel, which kind of gets dislodged and goes to the brain and causes the stroke. Most commonly, we see this in people who have history of atrial fibrillation, and that's why they'll be taking blood thinners. Another type of stroke is the thrombosis, which is a blood clot formed within the artery, supplying the blood to the brain. Next slide, please. The hemorrhagic stroke, about 13% are caused due to hemorrhage, which is due to breakage of a blood vessel and causing bleeding in the brain. This can be due to trauma or a ruptured aneurysm, and most of the times we see is due to the hypertension and uncontrolled blood pressure. There can be two types. One is intraparenchymal and subarachnoid hemorrhage. Intraparenchymal is the one wherein a blood vessel bursts and leaks blood into the brain tissue. The most common time we see is due to hypertension. Subarachnoid is when the blood vessel bursts near the surface of the brain. Next slide. Most often we see what is called as transient ischemic attack, and people call it as a mini stroke. This causes the stroke-like symptoms, but the symptoms are rapidly reversible. So this is also caused by a clot, but unlike the stroke, the blockage is not completed or permanent. It's usually temporary and does not cause any permanent damage to the brain. But what it means is this is a warning sign that the patient is at high risk of having future strokes. So all TIAs must be considered as a potential for stroke, and then we need to look for all the risk factors and treat them. This is also a medical emergency because 15% of all strokes occur after a TIA. So it's always better to consider this as a stroke unless otherwise proven. Next slide. So these are some of the common stroke symptoms that you may encounter in the field because you are all the people in the first contact with the patient. So if they have a stroke on the right side of the brain, they may have slurred speech and weakness or numbness of the face, left half the face. They can have left-sided neglect, and their eyes may be looking to the right. And they can have the strokes on the left side of the brain, then they'll have the speech problem, meaning aphasia, that they're not able to speak properly or understand what we are saying. So that's a problem with comprehension. They will have left gaze preference, meaning their eyes will be looking towards the left. There are brain stem stroke symptoms, which would be like intractable vomiting or vertigo. That's why even though vertigo is not always due to stroke, we consider that we need to rule out stroke before we say it is due to other causes. They can have speech problems and abnormal eye movements. And the most common thing with brainstem stroke will be the decreased level of consciousness. And crossed findings, meaning they may have facial droop on the left side, but weakness on the right side. The intracerebral hemorrhage, intraparenchymal hemorrhage usually presents with intractable nausea and vomiting and severe headache and weakness. Subarachnoid hemorrhage, typically the patient will be saying is the worst headache of my life, and neck stiffness and pain. Next slide.
Hey, Dr. Vishwal, the
Yep.
brainstem stroke, are they very prevalent? Are those rare or?
I would not say rare. We do get quite a few strokes, and when we say brainstem, it may be due to medulla, midbrain, or pons. Most commonly, we see the pontine strokes, and I would say roughly around 20% of the strokes. They are not that rare. They do happen.
Okay, I see. Thank you.
So one we have to always also consider is what are the things that also look like stroke and may not be stroke, but it's always better to consider them as stroke unless we rule it out. A person with alcohol intoxication can have a slurred speech, but it's very hard to decide whether he has a stroke or not. So, and the cerebral infections, depending on where they have infection in the brain, like cerebral abscess, can cause weakness. Drug overdose can alter the mentation and can cause some of the symptoms of stroke, like slurred speech, epidural hematoma, and hypoglycemia is one of the common things. So that's why we mandate and look for the blood glucose as soon as a person has symptoms of stroke. If we correct the hypoglycemia and it improves, then we are pretty sure that it's not a stroke. Metabolic disorders like low sodium and high calcium can also cause some of the symptoms which mimic the stroke. Migraines are common. We quite often see migraines which are called complex migraines. They can, or hemiplegic migraine, which typically kind of runs in the family. They will not have that much of a disability when compared to stroke, but they will present like a stroke. Bell's palsies, which is like a involvement of the facial nerve, not necessarily be a stroke. And then a person who may have a seizure and after seizure may have weakness on one side of the body, we call it a Starts paralysis, which also looks like a stroke. And there are other conditions like brain tumors and hypertensive encephalopathy. Next slide. So some of the EMS policy recommendations. So these are most of the information I got on the website to the American Heart Association and American Stroke Association. So you all have the access to this. I just thought briefly discuss and answer your questions if you have any. So as you all know, like the EMS people are very good in supporting the ABCs, and perform the pre-hospital stroke assessment, which is like an VAN score, and looking for the other red flags, like whether the patient is taking any blood thinner or not. And then you all do a great job in looking at a screening for a patient, whether he's taking the blood thinner or not. Establishing the time when the patient was last seen normal, and rapid transporting the patient to the primary stroke center or comprehensive stroke center. EMS sometimes can bypass hospital without stroke resources if the stroke center is within reasonable transport range, meaning, time is essence in stroke. We do not want to waste any time. So it's always better to transport the patient to a facility where there is the stroke team is available, and initiate the code stroke so that all the stroke team is alerted. And as I said, we have to always check the blood glucose because that's one of the easiest to treat. So I just wanted to give a brief overlay, like how many brain cells and the neurons are lost every second. If you can see that there is per stroke, per hour, and per minute, and per second. Every second counts, and then every second delayed will result in 32,000 neurons lost, which is like 200 meters, and it increases the aging by 8.7 hours. If we go by 1 hour delay, there are like 120 million neurons lost, and then 830 connections lost, and about 447 miles of the fibers are lost, which delays the age by accelerated aging by 3.6 years. So I just wanted to show this slide, like to show why time is very important and why we need to bring the patient as soon as possible to the ER. Next slide.
This would be awesome for a presentation out in the streets, so that the public would know, hey, don't wait that 3.5 hours before you call for a stroke symptoms.
Yeah, because like,
That's exactly what yeah. Sorry, I just, no, that is.
Yeah. So the goal of stroke care is to minimize the brain injury and improve the patient's recovery. And, family members should be educated, and, they should recognize the stroke and call the 911. EMS rapidly arrives at the scene and perform their stroke assessment, and they rapidly diagnose and treat the patient. And I'm very thankful that we have a strong EMS team, which bring all those patients to the ER. They have been pretty good. So next slide, please. We'll talk about this later. Okay. So what do we do in the stroke assessment, right? So you all do the VAN score. And so previously there were different scoring systems like PASS and GFAST and FAST. They would just recognize the stroke, but would not necessarily recognize a large vessel occlusion. And those would help us in determining whether we should give TPA or not. So there are other stroke scoring systems like RACE and StrokeVan and CSTAT, which is Cincinnati Stroke Triage Assessment Tool. These scoring systems help if there is any large vessel occlusion or not. If a VAN score is positive, that means we are dealing with a large vessel occlusion. Even though they're not within the TPA window, they should be rushed to the ER because they may be candidates for the thrombectomies. Next slide, please. So what do we do in the hospital levels of care? In the primary stroke center, such as our Union Hospital, we stabilize the patient, provide emergency care. We determine whether the patient is eligible for TPA, and we do the imaging like CT head, CTA, angiogram of the head and neck to look for any large vessel occlusion, CT perfusion, and depending on if they need thrombectomy or not, then we will transfer to the patient's comprehensive center if they need thrombectomy. If not, we'll admit and complete the treatment for the stroke. In a comprehensive stroke center, they have capability to provide all levels of care, including the neurocritical care. And usually we transfer the patients who might benefit from thrombectomy. Next slide, please. So IV TPA, we need to have a clinical diagnosis of stroke within the 3 hours and 4.5 hours of loss in normal. They should not have any recent trauma or major surgery, no history of any intracranial hemorrhage or bleed in the recent past. And also, and as we discussed about TIA, if they have rapid improving symptoms, then we don't give TPA, but it's always better to consider TIA as a stroke unless otherwise proven. And there should not be any seizure at onset, but that's debatable again. A patient may have a stroke and have a seizure, so it's up to the discretion of the neurologist and the ER physicians. Blood pressure should be less than 185 or 110 without major intervention. If not, then we do treat the blood pressure and then give TPA. We get a stat CT. We have a great protocol in the ER. Patient gets the CT immediately, and if there is no evidence of hemorrhage or major infarct, then we give the TPA. Also, they should have a normal blood glucose and platelet levels, normal bleeding parameters. Next slide. So these are some of the inclusion and exclusion criteria that we use in determining whether patient needs TPA or not. And sometimes it would be very helpful if you can get some history from the patient or their family. If the patient is already on a blood thinner or not, then we can decide what we need to do. Next slide, please. So this is thrombolytic therapy again. I don't know why I put this slide here. Okay, it's the same information. Okay.
Better?
As Beth was mentioning about the stroke and that share, which was a wake-up stroke, there is no upper limit for the last well-known normal. But if patient has a stroke, we typically tend to do an MRI and then look for some of the MRI features. And if there is no obvious stroke, typically the MRI is pretty sensitive and it can show the stroke within a few minutes, like 10 to 15 minutes, it will start showing the changes of the stroke. So we compare with different sequences on the MRI and see if the stroke is completed or it's a stroke in evolution or whether they need the TPA or not. In some of the studies, they did give the TPA, and then there was some increased risk of bleeding, but the outcome was good. This is something we are working on developing a protocol. And so Alteplase can be beneficial if there is unclear time of onset, say if they're more than 4.5 hours, or if we don't know last well-known normal, we do the MRI. We try to do different sequences, as I mentioned, diffusion weighted and flare images, and try to see if patient already has completed the stroke or he's in the process of completing the stroke, and then decide. This is a class 2A evidence, which is not a great evidence, but that is something which is always evolving and progressing. So I just want to briefly go through a case. This is a 68-year-old female was brought to the ER with right facial droop, right-sided weakness, and difficulty speaking. She was last in normal was 6 a.m., which was Illinois time, and this is an actual case that we got. And they had some trouble with logistics, so they were not able to bring her on time for the TPA. When we examined her, she had moderate expressive aphasia, moderate UMN paralysis, and our vitals were stable. Her NA stroke scale was 6. We did a stat head CT, which started already showing a subtle hypodensity in the left MCA, meaning middle cerebral artery territory, but it was not a big stroke. Next slide. So do we give IV TPA, yes or no? We cannot give the TPA because she's already outside the TPA window and the CT head is already showing a small stroke. So we went with CT angiogram of the head and neck and the CT perfusion. Next slide, please. So this is what the CT head looks. If you can see on the left side, you can see there is already small hypodensity here. And on these colorful images, blue is bad. Wherever you see blue, that is the part of the brain which is at risk of stroke. You can see in the middle image, the blue is smaller when compared to the other one. That is the core, which is already infarcted. But if we do the thrombectomy, we can save almost half of the brain. I thought it would be interesting to show what exactly it means when we do the perfusion. We can see how much of brain has already stroked and how much of the brain is at risk of having a stroke and how much we can save the brain. Next slide, please. So this is something we use, what is called as a rapid CT angiogram. So as soon as we do the angiogram, CT angiogram, the artificial intelligence derived algorithm calculates, and it gives a images which says that this is the portion of the brain which is at risk of stroke if we do not do anything. As you can see, it's almost half of the brain. Next slide. So this is again the same CT perfusion. So this is the artificial intelligence derived process. And then we have a great team in our radiology. I don't know if Dr. Nufur is available. So he's one of our radiologists, intervention radiologists. If he's available, we always discuss and see if this patient is a candidate for thrombectomy or not.
Hello, Dr. Vishwas. I am here.
Yeah, Dr. Nufur, if you can give us some more information how we do the thrombectomy, that would be great.
Sure. So yeah, I see you're discussing that there's a penumbra on this patient, that there's a core infarct, which is a region that can't be salvaged, but there's an ischemic region, as was mentioned by Beth and you, the penumbra, which can be reperfused and can be restored. Can we get to your next slide out of curiosity? Right, so then we call this, and as you guys have alluded to, these large vessel occlusions. And not every large vessel occlusion is necessarily emergent. They can be chronic as well, but generally, if they're chronic, they don't present with stroke symptoms, or they don't have such a high NIH stroke score. So really, we're talking about the emergent large vessel occlusions, or emergent large vessel ischemic stroke, which is a funny thing to mention because in Canada, where my wife works at her hospital, they call it ELVIS, a code ELVIS, for emergent large vessel ischemic stroke. So anyways, in these cases, we often see the perfusion imaging that you had on the previous slide, and these are amenable to endovascular treatment, which has gotten much better in the last 5, 6, 7 years than in the 20 years prior to that. So it had long been a goal of interventionalists to perform this procedure, much like cardiologists will perform a cath for a STEMI. The idea would be catheterized for stroke, but the technology just wasn't there. And so newer devices and better patient selection are what have allowed this to happen. So we saw better patient selection on your prior slide because we can select for patients that will benefit, patients that have tissue that can be restored. And better devices like we see on this slide, this being a stent retriever, a little nitinol basket that can be deployed within the clot and mesh the clot within it and then pull the clot right back out. And these are relatively recent devices. There's been a lot of studies using them, and it's a very hot area of research still. So I have one slide I'll share with you briefly. Let me get over here, just to give you an idea of what it looks like. I'm going to steal this screen from you. Hopefully that's okay.
Sure, absolutely.
There. All right, so here's a slide from a mishmash here of slides. If you can all see this, there's the non-contrast CT head on one side of the image, and an arrow is pointing to a small hyperdensity, and clot is hyperdense relative to regular brain tissue, right? Blood has lots of iron, metal in it, and so clotted blood is hyperdense. And on an angiogram, we can see that the red arrow on the first image corresponds to the blue arrow where there's clot in this MCA in the middle cerebral artery, right actually where it branches kind of into the what we call the M2 or the more distal segments. And then on the final image, we don't see any devices, but we see that that clot has been sucked out. And now there's filling of those distal branches. And so this whole right MCA territory has been restored. So this would have otherwise been a devastating clot. And I have one or two more slides to show since I have the pulpit. Here we can see, yes, here we can see some other emergent large vessel occlusions. And these are ones that are taken from a paper where they looked at TPA versus endovascular therapy. And so we know that TPA doesn't work well for these chunky large clots. We've always known that, and the recanalization rates are very poor. They're better if it's very early, but very often we can't give it or we can't give it early. And so they just don't recanalize, which is devastating. And so if we look at some slides taken from the American Stroke Society or Association, like Dr. Vishwas showed, no endovascular treatment, 28% chance of getting independent functional outcome versus about 50% with endovascular treatment. And so that's why we put so much emphasis on these LVOs. And I hope that if we develop this program here, we'll do a real service to the community because it's going to save a lot of patients and their families from devastating outcomes, and also for the economics of the community as well. You know, so many patients are saved from long-term care homes. They have functional independent outcomes, and it doesn't take, oh, sorry, get out of that. It doesn't take more than usually, you know, 20 minutes to go in and pull these clots out. So it's very achievable. Anyways, I'll go back to you, Dr. Vishwas. Let me seed this.
Oh, thank you, Dr. Nufur. Thanks very much for that presentation, and it was very educational and very helpful. All right, Barry, any questions for us?
I don't, anybody? Dr. Vishwal, we appreciate very much. Dr. Nuffer, thank you for your input. I do have a question for Dr. Nuffer if he has a second. That, the picture that had the, well, you said that the cage or whatever, the plat, you know, the thing that goes in and grabs the, do you push that
A
past?
stent retriever, we call it.
Trigger, thank you. Do you push that past the clot and then pull it out, or do you put it right in the middle of the clot and pull it out?
Yeah, we put it right in the middle of the clot and then expand it so that it forms in the clot, sort of like a mesh, you know, capturing the clot.
So it doesn't leak, you know, it has a tendency, does it ever leave pieces of it in there, or is it something that it usually grabs all of it?
That's a very good question. You're getting into the subtleties of the procedure, but yes, sometimes pieces do break off. We have techniques to try to avoid that. We actually put a suction catheter behind that, so we're constantly sucking while pulling.
All right, I was just curious. To my mind, I would have thought to myself, if it doesn't grab it all, it's still going to leave a piece there. But that makes more sense. Thank you for the time.
Thank you, guys.
All right, guys. That's going to do it for us. I do have some things I want to talk to everyone about. Again, thanks to everyone that did the presentations today. Truly appreciate that very much. Hey, May 18th, the week of May 16th is EMS week. On May 18th, Regional Hospital will be hosting the cookout this year. I believe it's going to be catered by Rick's Smokehouse again. I will tell you, because it's going to be a regional, the weather will be beautiful. That's just the way it works. It rains here, it's pretty down there. Going to be the 18th, there will be raffles and things to give off and EMS gifts. So I encourage everyone to come down at 11. I believe the mayor's scheduled to be there around 11:30-ish. The different services are going to help with some desserts and some drinks, but regional is going to be doing that. We're going to be doing some gift cards. I mean, trauma is going to be putting some, our trauma program is going to be putting some stuff in there for raffles too. So it's going to be a good time. I believe that Christina has the mobile simulation lab from the state's going to be there that day, maybe even a couple days through the week. There'll be some other stuff. I know that we're going to have some stuff out on the counter, just, you know, snacks and stuff for the week, just to let you guys know how important you truly are in this community as EMS. Another thing I would like to mention, make sure you're up to date on your, make sure that you're 100% up to date on your ACLS, PALS, BLS, ITLS, or PHTLS. If you have new certifications, get them to your supervisors, to your directors, so they can get them to me and I can keep track of that. By the end of this month, everyone's supposed to have all of those. If you're a paramedic, you have to have all 4 of those to work in our system. So make sure that you have that done. That's important. And then one other thing is, I was contacted by a friend of mine that here at the hospital that owns the part owner of the drag strip. And again, they're looking for EMTs, paramedics to work at the drag strip. If you're interested in doing that on the weekends, let me know. I will get you the contact information. I actually sent the contact information to the fire department, to Park County, to Ileana, and to Transcare. So if you need that contact information, you can get it from them. But if not, you can email me. They're paying $15 an hour to go down there and watch the races and be there if you need it. So he's looking for EMTs and medics to spend some weekends down there at the Turo drag strip.
Hey, Barry, can I say something real quick?
Yeah, please do, Christina, please do.
It is a fantastic time. I used to do the track a lot. My daughter actually manages the concession stand over there, but you will have lots of beautiful days and not a lot to do. So it is the most relaxed environment ever, and you just get to sit and watch cars all day. It doesn't get any better than that.
Thank you. You have anything you'd like to add about EMS week? I think I covered it for you.
No, you absolutely did. You got it all.
Okay. If nobody has anything else, last thing, email me, text me, let me know that you're on, so that you can get credit for being on. I'll put it in the I'll put it on the attendance thing. So thanks a lot. Have a great day. And that's going to be it for today.